Good afternoon and thank you for the opportunity. So I'll be changing gears from anterior segment to the posterior segment. And as it is said that there is no right or wrong way of doing things, it is just the perspective as we look. So some of the slides I will be presenting few cases. Someone would think it or manage it differently, but this is what I have learned over the period of time with experience. So there is a long list of retinal pathologies that can coexist with cataract, and not only they impact the vision, and it is difficult to differentiate whether the vision loss is because of cataract or retinal pathology, but it can have impact on the outcomes of cataract surgery as well. So the list is long. I will be restricting myself because of the want of time to few. So this is not an uncommon situation where you have operated an uneventful cataract surgery and a diabetic patient comes back with a fall in vision after 2 months of surgery. And what you find is a cystoid macular edema. So diabetics, they do have a very high risk of developing cystoid macular edema, and this has to be kept in mind. And all of these patients, irrespective of what kind of cataracts they have to be put on a prophylactic NSAID for at least 3 months after surgery. Now, what in patients who have diabetic macular edema? Now, the diabetic macular edema can coexist with a significant cataract. And here, if you see that this patient had a vision of 624 with cataract and a center involving diabetic macular edema. So what we generally prefer doing in these cases is combining a cataract surgery with intraocular steroid or anti-VEGFs, so that we deal with both. As Dr. Vinita was saying, they were dealing with both glaucoma as well as cataracts. We try to deal with both DME and cataracts together. But you can always do anything else, like you can treat the DME first if the cataract is not very significant, or you can treat the DME post cataract surgery. But always remember that after cataract surgery, the DME would increase because there is an increased chance of progression of DME. So your outcomes, because as cataract surgeons, you want 6/6 or even 6/5 visions. So it is better to treat DME first, or you combine it with cataract surgery. So these are the evidences. Now, what about PDR? Now, in patients with PDR, usually the patients with PDR progress very rapidly post-cataract surgery. So it is important that we treat these patients, as in this case, we started lasering this before we jumped in doing cataract surgery. We did laser, gave intravitreal anti-VEGFs, and the patient later on developed vitreous hemorrhage. That is when we combined cataract surgery with a pars plana vitrectomy, and this is post-pars plana vitrectomy. So in PDR, the risk of progression to high-risk PDR is very high after cataract surgery, and if possible, treat these patients before you go and do cataract surgery. One point of caution is that if you are unable to examine the posterior segment in a case of PDR in the other eye, please don't inject anti-VEGFs without doing a good thorough examination of the posterior segment. Now coming to AMD, so it is also not very uncommon to find these patients who come with cataract and AMD together, and in our setup usually the patients come with an advanced AMD. So the cataract surgery is the only option for them. But if you have an active AMD, then you can combine cataract surgery with anti-VEGFs. Now there is a debate whether AMD progresses more after cataract surgery. I don't think so, but there is definitely a transient increase in retinal thickness after cataract surgery, although there is no evidence that there is increase in number of injections required after cataract surgery in patients with AMD. Now macular roll and vitromacular interface abnormalities are also not uncommon to find with cataracts. Usually we combine cataract surgery with macular roll surgeries in these cases because the chances of progression of cataract after macular roll surgery is quite high, and as I said, you want a good outcomes. So combined surgery gives a quicker rehabilitation, it is cost saving and has less predictable, however it has got a less predictable refractive outcome, so that you have to take care of. Now in ERM, there is always a dilemma whether to do a combined ERM peel or to do just the cataract surgery. Now if you have a patient who has symptoms of discs distortion more than blur, then probably ERM is at the cause of it. And so a combined procedure may be beneficial. Similarly, if you do an OCT and you find that the foveal contour is grossly distorted, then that patient might require an ERM surgery combined with a phaco emulsification. But usually what we do is a sequential. So you do a cataract surgery, and if you find that there is problem, there is distortion, then you go ahead and do a ERM removal. This is because in most of the cases, and there is a recent meta-analysis also, they have suggested that in most of the cases, the ERM peeling may not be required at all. So another situation is, which is very common, is inherited retinal disorders like RP, which is the commonest one with cataract. And because in these patients, we, at least at present, we do not have much to offer, we usually do cataract surgery so that there is an increase, there is some kind of improvement in the vision that we can get. But one thing that helps you in predicting the outcomes of cataract surgery in these patients would be an OCT. And if you find that the outer retina is disrupted, the ellipsoid zone, the ELM, then these patients probably would not improve with your cataract surgery. So that brings to me to the point that whether we should be doing OCT in all our patients with cataract surgery. I don't know the answer, whether it is, as I said, there is nothing right or wrong in medicine. But what this meta-analysis tells us that OCT screening before cataract surgery picks up about 15% of macular pathology. And this is one of our case. You can see the fundus looks quite innocuous. And when you do an OCT, you will find that there is a type 1 CNVM with SRF. So in most, and this is more common with vitreoretinal interface abnormalities. So, and you can prognosticate your case by doing an OCT. So the jury is on. You can do OCT if possible in all your cases with cataracts. So to conclude, several retinal pathologies may coexist with senile cataracts, and cataract surgery in most of the cases with retinal pathologies are safe, and they do improve vision. And post-operative evaluation and pre-operative evaluation and planning is the key to success. Thank you so much.
Thank you, Dr. Alok, for the nice talk.